The urinary system cleanses soluble waste from our blood. The kidneys are the workhorse of the urinary system. They're responsible for many functions. They regulate water and water osmolality in the body. They regulate ion concentration in extracellular fluid. They ensure long-term acid-base balance in the blood. They excrete metabolic waste and foreign molecules like drugs from the blood. They also produce two hormones. Erythropoietin is the one that stimulates the bone marrow to produce red blood cells, and renin helps control blood pressure. It is the kidneys that converts vitamin D to its active form. The precursor substance is made in the skin. And finally, the kidneys will carry out gluconeogenesis during prolonged fasting. Normally this occurs in the liver, but if fasting is prolonged, the kidneys can take over this function as well. The urinary system only has four parts: the kidneys, the ureters, the urinary bladder, and the urethra. As you see, the kidneys lie here in the body cavity. The ureters drain urine from the kidney to the urinary bladder, and then the urethra drains urine from the urinary bladder to the outside. Here you see the adrenal glands sitting on top of the kidneys. Notice the organization of the kidneys in reference to the aorta and to the inferior vena cava. We'll talk about the length of some of these blood vessels and the fact that the inferior vena cava comes down on the right side of the body and the aorta a little more on the left side of the body is why some of these veins and arteries are different lengths. The kidney lies retroperitoneally. It's behind the peritoneum, and it's between the T12 and the L3 vertebra. The right kidney is slightly lower than the left because the liver is on the right side and depresses the kidney a little bit. The organ is bean-shaped and has an indentation called the hilum. The same indentation on a kidney bean has the same name. Sitting on top of the kidney is the adrenal gland. The kidney is well supported and held in place by three layers of tissue. The renal fascia is a dense fibrous connective tissue that tightly adheres the kidney to the back of the body wall. Perirenal fat surrounds and cushions the kidney. The fibrous capsule is a transparent, thin layer that helps protect the kidney from infection. Here you see the kidneys lying back here on either side of the vertebra. Here is the peritoneal cavity, the peritoneum, so it's behind the peritoneum, retroperitoneal, and between T12 and L3. Since the ribs come downward a little bit, the ribs provide some protection for the kidneys. Fatty tissue helps hold the kidney in place. If there is a loss of fat, either because of extreme starvation or rapid weight loss, the kidneys may drop out of position. This is called renal ptosis. What happens with renal ptosis is the ureter may kink, and if the ureter kinks, then urine is going to back up in the kidney and put pressure on the kidney tissue. This is a condition called hydronephrosis, literally water on the kidney. Because of this pressure, severe damage can occur, tissue death can occur, and eventually renal failure. When we look at the internal anatomy of the kidney, there are two major areas. The renal cortex is the outer layer, and the renal medulla is the inner portion. The renal medulla is divided into the renal pyramids, which are cone-shaped tissue masses. The points of the pyramids point internally and are called the papilla. And then between the renal pyramids are the renal columns. The renal columns are how blood vessels and nerves are going to travel in the kidney. The renal pelvis is a funnel-shaped hollow space that is continuous with the ureter. The ureter leaves the kidney at the hilum. From the pelvis, there are major calyces, or hollow tubes that lead away from the pelvis. Each of these subdivide to minor calyces. The minor calyces collect urine which continually drain from the papilla, so each renal pyramid will have its own minor calyx to receive urine. Here is a cross-section of the kidney. We can see the renal cortex, and here's the renal medulla. In the renal medulla, we have the renal pyramids and the renal columns. The renal columns, you'll see, have blood vessels in them. This is how we're going to get blood vessels around in the kidney. And the renal pyramids have the papilla. Each papilla drains into a minor calyx. The minor calyces drain into a major calyx, and each major calyx drains directly into the renal pelvis, which is this hollow space here. The renal pelvis is continuous with the ureter. This indentation is the hilum. Besides the ureter leaving here, this is also where the renal artery enters and the renal vein exits. Pyelitis is an infection of the renal pelvis and calyces of the kidney. Pyelonephritis is when the infection involves the entire kidney. Most urinary tract infections are what we call ascending infections. The bacteria enter through the urethral opening. Because this is a system that has totally opened to the outside, there are mucous membranes that line the entire system. The bacteria can use the mucous membranes as a route to go deeper into the system. So bacteria from the urethral opening can travel up into the bladder, from there up the ureters and into the kidneys. In severe cases, the kidney will swell, the pelvis fills with pus. If this goes untreated, the kidney can be severely damaged. And of course, the treatment for any bacterial infection is antibiotics. The kidneys are continuously cleaning the blood. At rest, 25% of your cardiac output is normally delivered to your kidneys. This means that the renal artery is quite large as it branches from the aorta. Because of the location of the aorta with reference to the kidneys, the right renal artery is slightly longer than the left renal artery. Once the renal artery enters the kidney, it subdivides into the segmental arteries. These further subdivide into the interlobar arteries. The interlobar arteries are what are going to travel in the renal columns. As we get to the junction between the medulla and the cortex, the interlobar arteries branch into the arcuate arteries. These travel along that junction. Coming from the arcuate arteries are the cortical radiate arteries, or the interlobular arteries. These literally radiate into the cortex of the kidney. The afferent arterioles that feed the glomerulus will branch from the cortical radiate arteries, and then the efferent arterioles will drain the glomerulus. As we look at how blood gets out of the kidney, it's pretty much the same way it got in. The efferent arteriole is going to feed the peritubular capillaries. These are the capillaries that are around the tubules of the nephron. These will drain into a cortical radiate vein, which will drain into an arcuate vein, and then an interlobar vein. This will go down through the renal columns. There are no segmental veins. The interlobar vein will drain directly into the renal vein. Again, because of the location of the kidneys with respect to the inferior vena cava, the left renal vein is a little longer than the right. The renal veins drain directly into the inferior vena cava. So as we look at the blood supply, the aorta feeds the renal artery. We get these segmental arteries, which branch into these interlobar arteries. These are the ones that are going to travel up the renal column. As we get here to the junction between the medulla and the cortex, we get the arcuate arteries. These have the cortical radiate arteries, and here we see the efferent arterioles. These will go into the glomerulus. The efferent arterioles will come out. They'll go into the peritubular capillaries, and those will drain into the cortical radiate veins, the arcuate veins, the interlobar veins. So here we see this interlobar vein, and they drain directly into the renal vein. And the renal vein will drain into the inferior vena cava. The renal plexus that serves the kidney is a variable network of autonomic nerve fibers and ganglia. This is primarily supplied by the sympathetic fibers. The sympathetic fibers are the ones that control the smooth muscles of the blood vessels, so the sympathetic vasomotor fibers regulate renal blood flow. They can adjust the diameter of the renal artery. This is important because blood flow influences the formation of urine. The nephron is the functional unit of the kidney. There are over 1 million of these in each kidney, so you have 2 million or so of these in your body. These are the structures that actually form the urine. The nephron has two major structures, the renal corpuscle and the renal tubule. The renal corpuscle is composed of two parts. The glomerulus is a tuft of capillaries. These are fenestrated capillaries, so they're very porous. They can allow large amounts of solute-rich, protein-free fluid to leave the blood. We call this fluid the filtrate. The glomerular capsule, or Bowman's capsule, is a cup-shaped hollow structure that's continuous with the renal tubule. It's going to be around the glomerulus and capture the filtrate. Now the renal tubule really kind of dead ends, and we just sort of push the tip in to make this cup-shaped structure around the glomerulus. The parietal layer of the glomerular capsule is the outside. It's the boundary of the capsule. The interior layer, the layer that's up against the glomerulus, is called the visceral layer. This tightly adheres to the capillaries, and there are some special modified epithelial cells that are a part of the blood filtering process. The other part of the nephron are the renal tubule and collecting duct. The renal tubule has a proximal convoluted tubule, a nephron loop or the loop of Henle, a distal convoluted tubule, and this empties into the collecting duct. Several different nephrons will empty into each collecting duct. The collecting duct is capturing the urine. These collecting ducts are what travel through the renal pyramids, and they fuse and deliver urine to the minor calyces through the papilla. Cortical nephrons are in the cortex almost exclusively. They are about 85% of the nephrons in the kidney. They have a short loop that just barely goes into the renal medulla. The juxtaglomerular nephrons are the ones that are very near the junction. The nephron loops are very long and go very deep into the medulla. The cortical nephrons are more involved in absorbing material from the filtrate. The juxtamedullary nephrons are more involved in producing a concentrated or dilute urine. So here is a basic nephron. Here is your arcuate artery and your cortical radiate artery. The afferent arteriole is feeding the glomerulus. Here's the efferent arteriole draining it. The renal capsule here, the glomerulus and Bowman's capsule, okay, just around that. Filtrate can be captured here and then will travel through the renal tubules. So these are the proximal convoluted tubules. They're a little twisty, but they're close to the glomerulus, so they're proximal. They're going to loop into the medulla. This is the nephron loop or the loop of Henle. They'll come back up, back into the cortex. We have the distal convoluted tubule again, a little twisty, but it's further away from the glomerulus, so that's why it's distal. And it will drain into the collecting duct. And notice how several nephrons drain into this collecting duct. The collecting duct then goes down through the medulla and will end up at the papilla of the renal pyramid. The afferent arteriole comes from the cortical radiate artery and feeds the glomerulus. The glomerulus is specialized for filtration. The efferent arteriole is going to accept blood from the glomerulus. It is the efferent arterioles that will feed the peritubular capillaries of the cortical nephrons, or a group of capillaries referred to as the vasa recta in the juxtaglomerular nephrons. The peritubular capillaries interweave with the renal tubules. The vasa recta surround the nephron loop deep in the medulla. Blood from the capillaries, whichever kind they are, will enter the cortical radiate vein. So as we look at the blood flow, we have the arcuate artery. Here is that cortical radiate artery. This is one of the cortical nephrons with the very short nephron loop. This would be anything below the arcuate artery and vein is the medulla. Anything above it is the cortex. So we have a very short renal loop. And here are the peritubular capillaries, all interwoven around the proximal and distal convoluted tubules. Over here, the afferent arteriole is feeding the glomerulus. The efferent arteriole comes out, but this time the capillaries are the vasa recta. Recta means straight, so we don't have so much interweaving or intertangling. Rather, they're kind of straight, but they go back and forth. And this longer loop is going to be involved in adjusting water in the urine. These capillaries will be interested in picking up materials we're reabsorbing from the filtrate. These capillaries are more involved in adjusting the water in the filtrate. Notice that some of the renal tubules come very close to the afferent arteriole. There's a special structure here that helps control blood pressure. That structure is the Juxtaglomerular Apparatus. We have one associated with each nephron. It's an area where the most distal portion of the ascending limb of the nephron loop lies against the afferent arteriole, the one that's feeding the glomerulus. At this point of contact, both are modified. They have some slightly different cells. In the ascending limb of the nephron loop, we have a group of cells known as the macula densa. These are chemoreceptors that monitor sodium chloride content of the filtrate that's entering the distal convoluted tubule. In the smooth muscle cell walls of the arteriole, we have some granular cells. These are sometimes called the juxtaglomerular or JG cells. These enlarged smooth muscle cells release renin. They have special granules in them that contain renin, and renin is going to help control blood pressure. There are some mesangial cells. These are outside the juxtaglomerular complex. They're actually between the two. They have gap junctions in them, so they allow messages to pass between the two groups of cells. So here you see that ascending limb. Here are the macula densa cells. Here's the juxtaglomerular complex, this whole thing right here. Here are those special cells in the smooth muscle, the ones that control renin release. These cells are going to be responsive to sodium chloride levels in the filtrate. And here are the mesangial cells, the ones that help communicate between the two. Here's the renal corpuscle. You have the glomerulus. This would be that parietal layer. Here would be the visceral layer, and you can see the cells are sort of different looking in that visceral layer. Urine formation is a three-step process. Filtration is the first step. This is a function of the glomerulus. Basically, at the glomerulus and Bowman's capsule, we're going to collect a filtrate. It's pretty much going to be plasma without cells or protein in it. The next step will be tubular reabsorption. This primarily occurs in the proximal convoluted tubules, but some reabsorption occurs all along the tubules. Here we need to reclaim what we lost in the filtrate. We need amino acids back, we need glucose back, we need some ions back, so we have to reabsorb that material. Then we have tubular secretion. This occurs primarily in the distal convoluted tubule, but some occurs all along the tubules. Here we selectively remove substances from the blood. This may be stuff that didn't get filtered in the first place or that got passively reabsorbed and we really need to get rid of it. So as we have the afferent arteriole and the glomerulus here, the first step is filtration, making the filtrate. Then primarily in the proximal convoluted tubules we'll reabsorb material we need. And primarily in the distal convoluted tubules, we will get rid of any substances we really want to remove from the blood. So this reabsorption and secretion occurs in those peritubular capillaries, and then we will send the blood to the cortical radiate vein. Filtrate formation is a passive process that's driven by hydrostatic pressure. The filtration membrane is composed of the epithelial cells of the blood vessels, the epithelial cells of Bowman's capsule, and their fused basement membrane. The endothelial cells of the glomerular capillaries are fenestrated, so they're very leaky. They allow all blood components but cells to get through them. The basement membrane, that fused basal membranes of both of the epithelial cells involved, act as a physical barrier. This helps keep the proteins out. Then the podocytes are the specialized epithelial cells of Bowman's capsule. They're called podocytes because they have little special foot processes that come out. These form filtration slits between the cells. There's a thin membrane that also catches large molecules. Water and solutes get through, but cells and protein don't get through. So here you see the afferent arteriole feeding the glomerulus. These are those specialized podocytes. You see we have simple squamous epithelium coming around in the parietal layer, but as we get here to the glomerulus, we alter those cells. So these cells wrap around the capillaries, and we have these little slits between the cells. This is the parietal layer. We will catch the filtrate in the cup, and the filtrate will then go into the proximal convoluted tubule. Now this is a closer view of those podocytes. See their little foot-like processes, they stick out, and these are the little filtration slits, and there are special little membranes on them that help keep molecules from getting through. In this schematic drawing, plasma on one side, which has hydrostatic pressure pushing on it, and the fenestrations allow a lot of stuff through. The basement membrane acts as a bit of a sieve, and then the slits between the podocytes with their little filtration diaphragm, their little slit diaphragm, captures large molecules as well. So that the filtrate we get in the capsular space is plasma minus the proteins and minus the blood cells. Hydrostatic pressure in the glomerular capillaries is what drives this process, and basically this is systemic blood pressure. We see a higher than normal capillary pressure in the glomerulus. This is because the efferent arteriole is smaller than the afferent arteriole, so there's a little resistance to blood getting out of the glomerulus. Since proteins do not get into the capsular space, proteins are kept back in the blood, there is no osmotic force that pulls fluid into the capsule. There are some oppositions to hydrostatic pressure. Because we're putting filtrate in the capsular space, there's going to be a little opposing hydrostatic pressure there. Also, we keep all of the proteins in the blood, so there's that colloid osmotic pressure in the glomerulus that helps pull water back into the glomerulus. As we look at the net filtration rates between the hydrostatic pressure out, the hydrostatic pressure back in, and the osmotic pressure of the proteins back in, our net filtration pressure is about 10 millimeters of mercury. The glomerular filtration rate is the volume of filtrate formed each minute by the combined activity of all 2 million glomeruli. This is directly proportional to three things: net filtration pressure, and this is the most important aspect of glomerular filtration rate; the total surface area for filtration. With 2 million glomeruli, you have a huge area; and the filtration membrane permeability. And we've just seen that between the fenestrated capillaries and the podocytes, we have a very permeable membrane. In a healthy individual, these last two are pretty constant. So the net filtration pressure, that's why it's the most important aspect, it's the one we can really control. We regulate the glomerular filtration rate by changing the glomerular hydrostatic pressure. If we raise the glomerular hydrostatic pressure, the net filtration pressure will rise. That means glomerular filtration rate will also rise. If the glomerular hydrostatic pressure falls by as little as 18%, we will drop the glomerular filtration rate to 0. Glomerular hydrostatic pressure, therefore, is very tightly controlled. There are two kinds of controls. The intrinsic controls are controlled by the kidney. The myogenic mechanisms involve smooth muscle activity. Vascular smooth muscle, you'll remember, contracts when stretched and relaxes when it's not stretched. So if we have a rising systemic blood pressure, that's going to stretch the arterial walls. This will make them contract. That will restrict blood flow to the glomerulus. We do this to prevent damage to the glomerulus, but when we do this, we lower the net filtration pressure and the glomerular filtration rate. Then we have the tubuloglomerular feedback mechanism. This is directed by the macula densa. You'll remember that those cells pay attention to how much sodium chloride is in the filtrate. If we have a high glomerular filtration rate, urine will be flowing through the nephron too fast for us to reabsorb material appropriately. So the sodium chloride level will be high when it gets to the macula densa cells. The macula densa will then cause vasoconstriction of the afferent arteriole to reduce net filtration pressure and glomerular filtration rate and allow the nephron sufficient time to reabsorb material from the filtrate. We can maintain a pretty constant glomerular filtration rate over a systolic arterial pressure range of 80 to 180 millimeters of mercury. If the systolic pressure drops below 80 millimeters of mercury, none of these autoregulation controls work. We have to use the extrinsic factors. The extrinsic factors are neural and hormonal mechanisms. The purpose of these mechanisms is to maintain a systemic blood pressure. The neural controls come out of the sympathetic nervous system. A falling blood pressure systemically will stimulate the release of norepinephrine. Norepinephrine will cause the vascular smooth muscle to contract. This will increase peripheral resistance and will raise blood pressure. This means that the afferent arterioles will contract as well. This will decrease glomerular filtration rate. On the hormonal side, we're using the renin-angiotensin-aldosterone mechanism. This is the main mechanism for increasing blood pressure. It's necessary to maintain the glomerular filtration rate. When we have a low blood pressure, we have release of renin from the juxtaglomerular complex. This is actually part of the sympathetic response. The sympathetic neurons will cause this release of renin. You'll remember that renin will activate angiotensinogen in the blood to angiotensin 1, which will be activated to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor. Also, angiotensin 2 will stimulate the release of aldosterone. Aldosterone will affect the renal tubules, causing them to save back more sodium. Where sodium goes, water follows, so we'll have more water going into the blood, increasing the blood volume, which will also increase the blood pressure. Low blood pressure or vasoconstriction of the afferent arterioles will reduce glomerular filtration rate. The macula densa cells will sense the low sodium chloride in the filtrate and will also stimulate the release of renin. So we have a double whammy for renin release here. When we have the reduced stretch in the mechanoreceptors, these also stimulate the release of renin. Other factors involved include some paracrines that are released by the effect of the renal arterioles. When we have a low urine output, less than 50 milliliters a day, this condition is known as anuria. This may indicate that the glomerular blood pressure is too low. Renal failure and anuria can also result if the nephrons stopped functioning. Now, this can happen in acute nephritis. Acute nephritis is a sudden inflammation of the kidney. This may resolve and the nephrons go back to working properly. Transfusion reactions will cause the nephrons to stop functioning. Also, crush injuries to the kidney can cause the nephrons to stop functioning.